Welcome to MedX Northwest. Launched in 1969 at the University of Washington in Seattle, MedX Northwest is the second oldest PA program in the U.S., and it remains the country's largest civilian PA program. Today, there are over 120,000 certified PAs working across the U.S., and MedX has contributed over 2,700 PAs to this rapidly growing profession. PAs are ranked consistently near the top of the best healthcare jobs list and the top 100 best jobs across the board. Back in 1969, however, statistics like these were anything but guaranteed. The country was facing a serious shortage of healthcare providers, especially doctors, while the number of people in search of medical care was increasing, following on the creation of the Medicare program in 1965. Something had to be done. Enter Dr. Richard Smith, who not only recognized the need, but had a pretty good idea of what to do about it. Create MEDEX Northwest, and in the process, help to create a new healthcare profession. Richard Smith was an extraordinary man. He was also an extraordinarily busy man. Impressive in his consistency and renowned for his steady focus, Richard Smith never lost sight of his commitment to progressive public health practices and to improving healthcare outcomes for all people, from the most local settings to the most global. Let's take a few minutes to dip into Dr. Smith's biography and pull out a few stories that trace the origins of MedX Northwest and the life of a true healthcare pioneer. We start with a story that Smith himself often told when asked where he got the idea for MedX Northwest. The year is 1951. Richard Smith, an 18-year-old Howard University freshman, is in the Cuban countryside, a volunteer with a Methodist missionary work camp. Smith was no stranger to the economic struggles and discrimination of his day, and yet nothing could have prepared him for the degree of poverty and hardship he was to encounter in pre-Castro Cuba. He remembers one afternoon in particular. He's assisting in a rustic health clinic. A small child wearing no diaper is crawling across the rough clinic floor, sick with diarrhea. As the child moves, a tapeworm emerges. Without missing a beat, a young community health worker reaches down and tends to this infant as best she can, before then turning her attention to the many other sick people waiting for care. While there were doctors available in the area, they were in short supply, attending to clinics of this size once, maybe twice a week. Otherwise, it fell to this one young woman to care for those who would file into the clinic that day, and the next day, and the next. As he watches this scene unfold, Richard Smith begins to ask himself, how much training has she had? 3 months, maybe 6? What if there were others like her? What if the answer to improved access to health care lay not simply in having more doctors, but increasing the number of non-physician healthcare providers? What if the caring, skilled, experienced hands of this young Cuban provider could be multiplied? Smith returned from his mission in Cuba to Howard University in Washington, D.C. He soon dropped his music major. Smith was apparently quite the piano player and singer in his day, in favor of pre-med. His primary focus became, perhaps not surprisingly, parasitology. Upon graduation, he entered the Howard University Medical School and came to be recognized as an expert on diseases borne by mosquitoes and parasites. His efforts came to the attention of the National Institutes of Health, and Smith was soon recognized as the first medical student ever to become a commissioned officer in the Public Health Service. In 1957, Richard Smith received his MD from Howard University. He was to go far, this new young doctor, but his memories of Cuba would never leave him. In 1961, the U.S. Public Health Service was put in charge of health care for volunteers in the newly created Peace Corps. This interested Dr. Smith, and he made his interests known within public health service circles. It wasn't long before he was invited for an interview with Robert Sargent Schreiber, the Kennedy administration's driving force behind the creation of the Peace Corps. Shriver tapped Smith to serve as a Peace Corps physician in Nigeria to ensure the health care and safety of Peace Corps volunteers in that country. Dr. Smith's rounds in Nigeria took him from community to community, some of which were up to 300 miles apart. His medical counsel soon became gospel to volunteers living in areas afflicted with unfamiliar diseases. Smith also provided care to the Nigerian locals in several mission hospitals. It's in that capacity that he came to train dressers, people who were charged with changing dressings. He taught the most competent among them to identify and treat malaria and fever. He then trained them to treat diarrhea, dysentery, worms, and malnutrition. Enough training, that is, to address some 90% of Nigeria's most common medical needs. Smith knew he was onto something. After 2 years in Nigeria, Dr. Smith returned to the U.S. and was appointed Deputy Director of the Medical Program Division of the Peace Corps. He assisted in directing the health programs of more than 8,000 Peace Corps volunteers serving in 46 countries. Smith completed his assignment as a Peace Corps Medical Director in 1965 and then took a staff position in the U.S. Surgeon General's office. His new boss, Surgeon General William H. Stewart, was focused on winning over the hearts and minds of the people of Southeast Asia by improving their access to health care. Upon his return from an official visit to the area, the Surgeon General declared, "We need doctors over there." He then approached Richard Smith, and they discussed the idea of physician extenders, an increasingly common term that was popping up in discussions of how best to respond to doctor shortages. For Smith, the notion of physician extenders echoed his earlier observations in both Cuba and Nigeria, and fit his developing ideas on the matter. Stewart presented Smith's ideas to a gathering of area officials. They were well received. One person asked, "But why isn't this being done in the U.S.?" This question caught Dr. Smith's attention and stirred his imagination. Yes, why aren't we doing this in the U.S., he wondered. At the same time, Smith was intrigued by the Feldsher system practiced in the Soviet Union. Feldshers were trained healthcare providers who traveled across the Soviet Union, where doctors were in short supply, to attend to the needs of wounded soldiers and civilian populations alike. The potential value of bringing a variation on the Feldsher system to bear on the troubled U.S. healthcare system was not lost on Richard Smith. By the mid-1960s, then, the seeds of what would one day grow into MedX Northwest were sown. But there remained a significant career milestone for Smith to reach before that could happen. Working with the Public Health Service, Dr. Smith assumed the title of Director of Operations. His most significant assignment in this role was to oversee the desegregation of all the hospitals in the United States. Desegregation was a required component of the newly created Medicare program. All hospitals wishing to become Medicare providers, and there were thousands, would have to be certified in compliance with Title VI of the Civil Rights Act. What did compliance mean? Minority patients could no longer be denied access to any service provided by the hospital or to any part of the hospital. Patient rooms, cafeterias, restrooms, even the blood supply had to be integrated. Qualified minority physicians, residents, nurses, and medical technicians could no longer be denied employment opportunities. Oh, and by the way, all of this had to be accomplished by the end of July 1966, or in about 6 months' time. Some 1,000 volunteers in support of the effort were transferred from the Department of Health, Education, and Welfare to the Public Health Service and were placed under the supervision of Dr. Smith. As things were underway, Smith received a phone call from Vice President Hubert Humphrey. The two of them had met at the White House Conference on Health in November 1965. "President Johnson wants you to go to Marshall, Texas," Smith recalls Humphrey telling him. "The president wants to send a message that he's deadly serious, and he wants that message to be loud and clear." So, at age 34, Richard Smith, an African-American doctor from the North and working on behalf of the federal government, was being sent to Texas as a walking message from Lyndon Johnson that desegregation's time was now and that it was to start with the hospital in Marshall, Texas. Lady Bird's hometown. Smith considered the possibility he could be killed on this assignment, and news images from the time suggest that his worries were not unfounded. But off he went. Smith met with the county hospital's board of trustees, who told him in no uncertain terms that they were not going to desegregate. His response? Well, all right, but you've just kissed $1 million of federal aid goodbye. Not a week later, Smith received a telephone call from the chairman of the hospital's board of trustees. The chairman told him that the board had just hired a new head administrator and that the hospital would, in fact, comply, as would the vast majority of the nation's thousands of hospitals over the next 6 months. Richard Smith would look back on this time as among the most difficult and frightening in his life, but he would also come to recognize that the assignment had taught him how to change attitudes and move an agenda forward, even in the most difficult of situations. Upon the successful conclusion of the 1966 desegregation effort, Smith's job in Washington, D.C. changed to that of an administrative caretaker, something that didn't particularly engage him. Instead, his interests were focused on putting his dream of expanded health care into action. Smith knew he wanted to pursue this dream on the West Coast. Already familiar with the leadership at the University of Washington School of Medicine, he headed to Seattle with the idea of developing a pathway for the vast numbers of medically trained military personnel returning home from the Vietnam War to re-enter civilian life as healthcare professionals. He approached Dr. John Hogness, dean of the UW School of Medicine at the time. Smith recalls Hogness calling it a crazy idea. Crazy, but intriguing as well. And that was enough for Richard Smith. Smith began the work of making this crazy idea a reality by teaming up with Dr. Jerry Bassett. Bassett and Smith had crossed paths back in Washington, D.C., when both were commissioned officers with the U.S. Public Health Service. Now Bassett was with the University of Washington. He had put in 3 years with the Navy as a lieutenant junior grade on aircraft carriers in Korea. So grasping the value of Smith's concept wasn't a big leap. Bassett understood exactly the target population for such a program. Former military medics and corpsmen, all highly skilled and experienced, but with very few opportunities to apply those skills and experience in the private sector once their tours of duty were up. The idea was to capitalize on their military training, find out what they knew, add academic training where necessary to fill in what they didn't yet know, and get them into civilian medicine where they were so sorely needed. Jerry Bassett joined the nascent program as its deputy director and was placed in charge of curriculum development. Dr. Smith determined that it would be a competency-based curriculum, meaning that the students would be required to demonstrate their knowledge, whether previously acquired as corpsmen or newly acquired through the program. As for the program's name, as Smith and Bassett kicked around ideas, wordplay took over. Physician extenders, extenders of medicine, medical extension, military medics. Hey, what about MedX? In June 1969, Smith and Bassett hired a small team of faculty and staff for the federal demonstration project known as MEDEX Northwest. Smith built upon his reputation as a talent collector by surrounding himself with people who were proven experts in their fields. Administrative whizzes, wartime surgical experts, expert grant writers, curriculum designers, community psychiatrists. He then stepped away and allowed them to do what it was they did best. In the meantime, the Washington State Medical Association, whose support would be critical, didn't know what to make of Smith's MEDEX Northwest project. Drawing from his experiences with the desegregation of the nation's hospitals, Smith knew that he had to sell his idea as a solution to be applied at the points of greatest stress in the state's healthcare system. So he requested a list of the state's most overworked doctors. Many were located in rural areas and small towns in eastern Washington, places like Tonasket, Odessa, and Othello. Places whose docs had had just about enough and were on the verge of packing up and leaving. Smith contacted these physicians and arranged town hall meetings in their communities. He and his colleagues met with them, talked with them, and presented them with a solution, MedX. Soon enough, doctors and townspeople alike were getting on board. They wanted to know what they could do to help make MEDEX happen in their community. Smith often claimed he was flying by the seat of his pants during these town meetings, but of course he knew exactly what he was doing. By getting local doctors, who in the late 1960s were usually the most powerful people in town, to invest in his idea by demonstrating how each of them could be a part of the solution. At the same time, Smith and his team were recruiting these small-town physicians to become preceptors, to assume an active role in the MEDEX students' clinical education outside the classroom. He also pushed the idea that they should in turn hire these students once they graduated. And so a familiar outcome in the professional history of Richard Smith began to fall into place in Seattle. By mid-1969, the Washington State Medical Association showed signs of support. Grant monies became available, and the MEDEX Northwest program was off and running. Smith and colleagues traveled to a number of Army, Navy, Air Force, and Coast Guard installations across the country, selling their project to the medics and corpsmen they met there, and soliciting applications for the first class of MEDEX students. The team's interests fell most particularly to Special Forces soldiers, who had the best training, they felt, and the most experience with independent or unsupervised medical work, often behind enemy lines in the mountains and jungles of Vietnam. 80 applicants were screened, 26 candidates were interviewed, and from that group were chosen the members of MEDEX Northwest. Class 1.
Every year, the Armed Forces discharge 6,000 medics and Navy medical corpsmen. Most of the discharged men turn to jobs in which their service skills are wasted. On the other hand, there is an acute shortage of doctors in many communities, especially outside the big cities.
Growing town of Othello, Washington is one place where the shortage has been felt most severely, but they've come up with a novel solution to the problem. Bill Curtis has the story.
Dr. Smith devoted 4 years of his professional life to establishing MEDEX Northwest. MEDEX graduates began finding their way into a wide range of communities, from the affluent to the middle class to the poor, from rural settings to urban neighborhoods. By 1972, Smith knew that MEDEX Northwest had all the makings of becoming a success, and he also knew it was time for him to move on. Because Richard Smith was not a settler, but a pioneer, an innovator, a creator of possibilities and connections. He left MEDEX Northwest in the capable and imaginative hands of the staff he had personally shaped. They would, in turn, pass the MEDEX torch on to the next generation, and they to the next one after that, and here we are today. You'll probably not be surprised to know that Dr. Smith did not slow down after moving from Seattle to Honolulu in 1972. Not a chance. Instead, his dream shifted to taking the MEDEX model global. It was a move that would in many ways bring him full circle, back to his time in 1951 with the Methodist missionaries in Cuba. In Hawaii, Smith and others created the MEDEX Group, an international organization devoted to training healthcare workers in countries where shortages were chronic, where there were few, if any, medical schools, and where functioning national health ministries were the exception. This work would take Dr. Smith and his colleagues across the globe to such countries as Micronesia, Thailand, Guyana, Pakistan, Lesotho, and back again. The MEDEX Group would be the focus of his work for the next 20 years. Richard Smith and his family continued to live on the island of Oahu until the time of his death on March 10, 2017. 9 weeks earlier, on New Year's Day, Smith was honored by President Barack Obama for his lifetime of service as a healthcare pioneer. Today, the journeys taken by MEDEX Northwest PAs are not unlike the journeys taken by the dressers in Nigeria, the felchers in the former Soviet Union, or by the community health workers in the impoverished hillsides of Cuba, working to make a real difference in the lives of all people, across the city, the state, the country, and the world. by expanding and improving access to health care. MedX PAs are, in a very real sense, multiplying the hands of Dr. Richard Smith.